Yes.
This is a 8-year-old Jack who is small for his age. Do his abdominal examination.
Age. Do abdominal examination. Okay, no problem. Okay, I will just write my template and we will start.
Just okay.
So, Dr. Yasser, Salam Alaikum. How are you? Hello?
Walaikum Assalam. I'm fine.
Yeah, you can keep the time.
Yeah, no problem.
Okay, 6 minutes, okay. Okay, good morning.
Good morning.
This is Dr. Noor, one of the children's doctor in this hospital. After greeting Jack and his parents, I will start communicating with him to see whether he is well communicating or not, as well as I will look whether he is well looking, not in distress.
Okay, he's not in distress.
Well communicating.
Yes.
Okay, then I want to check his weight, height, and head circumference and plot an appropriate growth chart for age and sex.
He's on 9th centile.
9th centile. Okay, I want to look for any unusual features in his face.
No.
No. Like in the form of upward slant of eyes, depressed nasal bridge, nothing.
Nothing there.
I want to see in the surroundings if he has brought anything or any central line he's attached to or anything in the surroundings.
No.
No. Okay. From the universal cue, I can just see his lower limbs. There looks to be a form of knock knees he has. And also there is some redness in his thighs, which I am not sure. Maybe.
Leave this. Leave this redness. We will discuss later.
Okay. Now I will start examining hands. I will start examining his hands for pallor, cyanosis, clubbing, jaundice, and palmar erythema and flapping tremors.
He is pale. Pallor is there. What else you want to see?
Any cannulation marks behind the hand?
Yes, there is.
There is cannulation marks. Okay, but no cyanosis, clubbing, nothing. Chronic liver disease, stigmata. Okay, then I will check his pulse and blood pressure.
Yeah, pulse, blood pressure is 140/90.
Okay. Pulse
and pulse is 100 per minute.
Okay, then I would like to look into his axilla to look for any lymph nodes and also any axillary hair growth.
No.
Okay, then I want to look into the face for eyes for pallor and jaundice.
Yes, there is pallor.
Pallor. Okay, then in the mouth, I want to look for any ulcers, high arched palate, any dentition, nothing.
No.
Then I want to look, I will palpate neck from behind for any lymph nodes in the neck. I will look into the chest for any central line, for any spider nevi and gynecomastia and any deformities in the chest.
No.
Nothing. Okay. Then I want to see the abdomen. I will do abdominal palpation standing at the foot end of the bed and also on both the sides to look for abdominal distension, position of the umbilicus, any dilated veins, any scars. And also I will ask the child to bend 45 degree to see for divarication of recti.
Okay, you can see there are two scars bilateral in the flank that is going towards the lumbar region back, and there is one scar right iliac fossa.
Okay, there is one scar in the right iliac fossa and two bilateral scars in the flanks. I want to see the right iliac fossa scar. Is it hockey shaped or? I
Yeah,
want
this is simple transverse scar, you can say.
answers.
Oblique, not
Okay,
transverse,
then I
oblique.
want to start my palpation. Will relax the child. I will tell the child if he has any pain, he can stop me anytime. And I will warm up my
Mhm.
hands and do the superficial palpation from left iliac fossa going in anti-clockwise direction, looking for tenderness.
Okay, continue.
Then I will do the deep palpation. I will start from right iliac fossa, go upwards for the palpation of the liver.
Liver is not palpable.
Then I will go from right iliac fossa diagonally to palpate the spleen.
No spleen.
I will try to palpate both the kidneys bilaterally by doing bellotable maneuver.
You cannot palpate, but you have found a mass in the right iliac fossa.
Okay, mass in the right iliac fossa. So I want to check this mask for shape, surface, size, consistency, and any tenderness in the mass.
Shape, surface, size,
Border.
tenderness, border,
Mm,
consistency.
yeah.
Okay, so shape is like oval shape, and the surface is okay, and the size about 4 to 6 centimeter.
Mm.
There is no tenderness. Border is smooth. What else? Consistency okay. Consistency okay. What else you want to see?
Okay, I want to percuss to see the dullness in the mass.
Yes, there is dullness.
Okay,
6 minute finish.
okay, I will
Continue,
want
continue.
to do the percussion for to look for any shifting dullness.
No shifting dullness is there.
Then I want to do the auscultation of vowel sounds. And also
Yes, there is.
renal bruit.
No, you cannot appreciate.
And
Continue further.
and back I will see for scars. As I know, there are 2 scars in the flank region already, and I also want to check the sacral edema and lower limb edema.
No.
Okay, today I examined 8 years old Jack for abdominal examination. On my examination, the positive findings are there is pallor, and there is pallor, and on abdominal examination there is scar in the right iliac fossa, and also 2 scars in the flank region behind, and there is a mass in the right iliac fossa which is 4 x 6 centimeters, firm in consistency, non-tender, smooth borders, oval in shape, and otherwise there is no stigmata of chronic liver disease in this patient,
Mm.
and chronic renal disease.
What
So
is your impression?
I think this is a case of renal transplantation with bilateral renal nephrectomy, bilateral nephrectomy.
Okay, good.
And also there is knock knees in his legs. Okay,
Yeah,
just
see,
1 minute.
that should
I'm
be
getting phone.
what is what.
Just 1 minute. Okay, continue.
Okay, please give me complete impression. Renal transplant, bilateral nephrectomy, plus
I told there is knock knees in his legs, and there are some redness, maybe bruises. I'm not sure in the thighs.
so what is this? Complete knock knees is there.
This may be chronic renal failure causing the rickets.
Yeah, this is renal osteodystrophy.
Okay.
Okay, and rash on the legs is due to maybe some medicines like methotrexate. Immunosuppression is going on after a transplant. Okay,
Hmm.
so one thing you forget whenever you have seen this picture, So you have found there is a signs of rickets kind of thing. So forget you wrist. Never ever forget about the wrist to check for the wrist and other signs of the rickets as well.
Wrist,
This same time.
wrist, and this.
Widening of the wrist will be. Yeah. So if you have found this one and you are looking for abdominal examination, that will be definitely either liver or some problem with the renal. So also describe the other finding like rickety rosary in the chest. You will want to check. You want to check for the Harrison sulci, and you would like to check for the head shape of the head, any frontal bossing, poor dentition, or malocclusion of the this dentist, and uh, widening of the wrist or other any deformity of the bones. So these things that should be mentioned, otherwise that's okay. And now I want to ask you, what are the indications of renal transplant? This question they ask, or
I
even I don't know properly.
bilateral uh, uh, indications for renal transplant. I think chronic renal failure with no good response to dialysis, or
Better,
bilateral.
you have anywhere we should study this one.
No, I don't
I could
have.
not find this.
Did you check in Mark? I think it's there. I will try to check the 1 minute only.
I told you I was completely busy. Just wake up. I
Oh,
came back and slept. Just wake up.
no problem. 1 minute only. I will.
I could not study today.
If there is
So
stage 3 CKD, we have to prepare for transplant. And if it is raised to stage 5, it's compulsory. But in UK and others, they will do on stage 4 this renal transplant, because we cannot stop once the chronic kidney disease start. Yeah, chronic renal failure starts. It will not stop.
it's not coming here. I don't know. Anywhere written this transplant chronic kidney notes on the chronic kidney disease.
In Muntasir, they mention about the indication for nephrectomy.
What is that?
I just give me 1 minute. I will open.
Open better. No, no problem. It will take time, but it will be good for Dr. Noor to memorize it.
Because I was going through.
So your question was what? Indications for renal transplant, right?
See, this case is also in. I am just checking. This case is there in Mrcpch. So they are taking from Mrcpch in UK. I think so. This case came in UK. Complete same case. Short for his age, 6 years old. Scar in the right iliac fossa, scar in the both lines on inspection at the back, and palpable mass in the right iliac fossa, and dull to percussion. But I don't know why they have given this dull to percussion. That should be of because this is transplanted kidney. It should be dull or I don't know.
Oh no, it's dull. It's organ,
No,
Okay.
solid organ.
the kidney is normally resonant to percuss because the bowel is there over.
Yeah.
Now in the
Yes.
transplanted
Yes.
kidney, they will place superficially, not so deep. So it
Okay.
will.
Okay. That will be.
But here, notes on chronic kidney disease, he hasn't given the indications, I think, in page 444.
I don't know. Some people was telling me there are specific indication and they are asking what is the indication. What is the indication for renal disease hemodialysis, what is the indication for the peritoneal dialysis? What is the difference between peritoneal and hemodialysis? And, what are the good for the hemodialysis and this?
Okay, we will do one thing. I
So,
think we need to go to patient info or something later. I will write your
okay,
question.
yeah, check and
Tell me the question
write these questions. I will tell you. The
indication.
first is what are the indication for renal transplant?
Okay.
And then the question they ask that what is the indication for hemodialysis and what is the indication for the peritoneal dialysis? This is yeah, peritoneal dialysis they are doing. Okay, then what is the difference between two, peritoneal dialysis and the hemodialysis, and which is good, which one is good from out of this? The third question they ask was that is written here in our Mrcpch. So what are the complications that can be associated with post transplant? So these are the complications like immunosuppressive therapy that can lead to the infections, rejections, dehydrations, and obstructions can be there sometimes. Adrenal crisis. Okay. So other points like what advices you will give. So live attenuated vaccines that should be avoided. Prophylaxis with cotrimexazole and prophylaxis against this CMV, valganciclovir you will give, and the scope trimexazole again the pneumocystic carinae, and advise mother if anytime he is exposed to varicella zoster, he should contact. And what will be the protocol further? Like if non-immune vaccinated before transplant and immunity regularly checked. If contact post-transplant and non-immune, varicella zoster immunoglobulin should be given. If chickenpox develop, then IV cyclovir. And nephrotoxic drugs should be avoided. This is another device to the mother. And how will you follow? So follow-up is with the weight, blood pressure, jugular venous pressure, laboratory testing, and regular monitoring of the creatinine versus baseline creatinine. So these are the things which should we remember. Okay, you have written the questions. Hello.
Yeah, I have written indications for renal transplant, indications for hemodialysis, peritoneal dialysis, difference between hemo and peritoneal dialysis, which one is good, and complications. Complications, I think it's mentioned in this Mrcpch.
Yeah, complications are there. Eyes to the mother is also there. Don't worry. This is only these 4 questions they are asking. If examiner will be from UK, they can ask you. I don't think so here in Jeddah they will ask you, but these questions from UK they can ask you. So just check this one from anywhere you can find.
Okay, no problem.
Okay.
Okay.
So they can ask you how will you manage. So what will you say? These are all the things
I
which
will
we have discussed. Yeah. Tell.
I will involve this child needs multidisciplinary team management. I will involve my consultant pediatrician, then nephrologist for the follow-up of his kidney renal functions, and also for immunosuppressive drugs. And if he is in acute infection, I will consider admission of the child and investigations like CBC, CRP, blood culture, urine analysis culture, and renal function tests to follow up. And apart from that, he has the bone profile is very important, and supplementation with calcitriol and calcium.
Okay. Yeah. So you will have to tell about management for the renal osteodystrophy. That will be vitamin D or calcitriol. Then you will use the he's small for his age, so you will consider for the growth hormone.
Growth hormone. So I will
Then
involve
then
endocrinologist.
he's endocrinologist. Then he's pale. You can think of erythropoietin injection. Again, you will involve your that one dietitian, sorry, hematologist, or I don't know, or consultant they are giving.
Or
I
I
don't know
think
which one.
nephrologist can consider this one, erythropoietin, maybe.
Nephrologist. Then what other you will have to involve? Just one, I will check. If anything, I am forgetting here.
Nephrologist, we finished. Endocrinologist for growth hormone. And
Yes,
general pediatrician,
vitamin D,
we finished.
vitamin D supplementation and phosphate intake. You will reduce. You involve the dietitian,
And
proper
also
dietic
reduce
review.
the potassium containing foods like fruits has to be
Yeah,
avoided.
yeah. Yes, growth hormone, correcting the anemia with using erythropoietin and iron supplementation. They have written also. So immunization, you will advise for the annual influenza vaccine that will be given this nasal vaccine. Not you cannot give. Yeah, this one IV you cannot give. So these are the things. So you will involve the dietitian, you will involve the endocrinologist, you will involve the nephrologist. Definitely will be from the nephrologist. You will involve the dietitian and bus this one only. And the this community pediatrician, social worker, all will be there also. Okay. So advice for mother is avoid nephrotoxic drug. First advice. Avoid proper hygienic advice. The third is avoid exposure of any time exposure, contact your GP to exposure to this
Varicella.
varicella. Then the
Right? Same for
huh?
varicella zoster, you will whenever
Yeah,
the
yeah,
child is exposed, you will check for the immune status. If he is
yes,
non-immune, immunoglobulin will be given. If he is immune,
yeah,
you will wait. Means you will be wait and watch if he develops any symptoms. Then you will consider acyclovir.
yes. Then is avoid live attenuated vaccines. Then is coming for the wear the bracelet because immunosuppression is going on. Wear bracelet. Then is advice is coming for prophylaxis against pneumocystic rhinitis, that is by cotrimoxazole, and the advice for the this PMV infection prophylaxis like valganciclovir you will give, and bracelet I have told you. What else you can use? I think these are the things only. Okay, so now I will do.
Okay.
Dr. Adnan, the only indication for a renal transplant is chronic kidney disease, because all the means diseases
Yes,
leading to chronic
yes,
kidney
yes.
disease.
You are right. Chronic kidney disease is the renal this indication, but they have mentioned somewhere. I'm not getting this from where I have. So this chronic kidney disease. Further, they have written some uricemia, hyperuricemia, or uremia, something. Potassium level should be like this, and
That's an
all these have.
indication for dialysis. Means
No,
renal
no, that is
replacement,
also,
just like
yeah, that is renal replacement therapy.
potassium more than 6, creatinine
Yes,
more
yes,
than 8,
that is renal
hypertensive
replacement therapy.
encephalopathy,
The
uremic
same
encephalopathy.
same things they have written. They have written there is not a indication that you have chronic renal failure and you will go for transplant. No, there they have written somewhere. I will check the specific indication in chronic renal failure. You have chronic failure, then further you have these two or three things. I don't know. Then
There
you
is
will go
one
for
preemptive renal transplant that I told you before.
mm,
I'm opening the wine harvest because it's written very good here.
share.
And
Take picture and share in the group better.
okay, no problem. There is one is preemptive transplantation, other is renal transplantation. And renal transplant is treatment of choice for end-stage renal disease. And preemptive is before dialysis. That means donor is living and
Mm,
before end-stage and dialysis. We can, and there are indication for nephrectomies, just like very large kidney. very significant polyuria, significant electrolyte disturbance, persistent proteinuria, hypertension,
Okay.
and recurrent pyelonephritis.
Okay.
These are the indication for
And
pre-transplant native nephrectomy.
send this in the better.
Okay, no problem.
Thank you, boss. Thank you. Okay, Dr. Noor. We'll continue further.
And one thing more regarding this chronic kidney disease rickets, this renal osteodystrophy, their findings are not prominent on the wrist. They are prominent on the proximal tibia and
Proximal tibia,
distal
that's why I
femur.
given this picture. In the wrist can be prominent, but very in the last, I mean to say last
Last
stage.
resort.
Yeah, that's
And
why I did not show that picture. I show only the
okay.
lower
And
limbs.
that's involved third and fourth digits,
Hmm.
according to the Wine Harris.
Okay, Dr. Noor.
Yeah,
Dr. Noor, what could be the other differential of knock knee? It comes in the some clinical or some video it came.
yeah, now
Only knock knee.
the rickets and some genetic conditions also can cause, like skeletal dysplasias.
Skeletal dysplasias can be there. There can be rickets. There can be osteogenesis imperfecta, and this I think sometimes these MPS
No, no,
MPS can present
that
with knock knee.
No.
wait.
MPS are
Ellis
reverse.
Van Creveld, Ellis Van
Reverse, yeah.
Creveld.
Ellis Van Creveld syndrome.
Yeah, Ellis
Yeah,
Van
which I was thinking.
But
This is also coming in the skeletal
imperfecta,
dysplasia.
osteogenesis imperfecta, achondroplasia, all these things will come under skeletal dysplasias.
These
Only.
all. This is also Alice Van Creveld is also coming under skeletal dysplasia. All these
So in
all
general, we
skeletal.
can say differential diagnosis will be, the broad term is skeletal dysplasia. In that we can give the other differentials.
Yeah.
Okay.
Renal osteodystrophy and the other hypophosphatemic rickets.
Yeah. So rickets.
Yeah, your friend Ola got that this one hypophosphatemic rickets. It came to her.
Okay.
Knock knee.
It came in the exam. Clinical.
Yeah. She told me that she lead towards this hypophosphatemic rickets.
In UAE exam, very easy came. Very easy.
It came in Jeddah.
No. Recent UAE exam just one day before. Yesterday. Yesterday it came very easy exam. Straightforward.
Okay, I will give you the case now.
What was the case? This one communication, yes?
Yeah. Talk
This one also 2 times.
to Janelle. Talk to Janelle. She is the mother of 3 years old Jack. Okay. She is asking for a series of tests and admission for Jack, as one of the students in the school had meningococemia and admitted. Background history: presently Jack is well with mild upper respiratory tract infection symptoms. Okay. And the child who has this infection is not in his same class. He is in an grade higher to him. Okay.
Okay. Now they are presented in emergency or?
Yeah, emergency only you can keep, no problem. Talk to Janelle. She's 3 years. Sorry, she is the mother of 3 years old Jack. Okay. Your task is clear for you. She's asking for series of tests and admission for Jack, as one of the students in the school has meningococemia.
Yeah.
And this student is not in his class, he is in a higher class. Okay. So you are ready.
Yeah, I will tell you.
Dr. Ayasir,
Who will
again timer 6 minutes and 3 minutes. Okay.
Okay, okay.
Okay, start.
Hello, good morning.
Good morning.
I am Dr. Adnan, one of the child and adolescent doctor in this hospital. Am I talking to Janan, mother of Jack?
Yes, doctor, it's me.
Thank you. Nice to meet you. So I'm here today to address your concerns about Jack condition. So would you like to wait for someone or should I continue?
No, doctor, no one is around. You can continue.
Okay. So may I know what are your concerns, Janan?
Yes, doctor. My son Jack has fever from 2 days, and he has some running nose and throat pain like this. So I am worried now because there is a news spread that one of the students in his school has some major bug infection with they
Mhm.
told some meningococci. They told like this in they were telling. So I am worried maybe my son will also have bug infection in the brain. So that's why I came here,
Okay,
doctor.
so yeah, I can understand your worries, Janin. So yeah, we have examined Jack, and he's having just a kind of common cold only. So may I know what do you know so far about meningococcal? This you are telling me the infections in the brain,
Yes,
meningococcal.
doctor. After I read in the internet, I got to know that the children will be more sick. They need admission in the hospital. And I am worried. Maybe now today is the first day or second day, he is fine. Maybe tomorrow, day after, he may have some problems. Since there is one child in the school having this problem, I want Jack also to do the blood test and some imaging
Oh,
to know.
okay, yeah, Janin. Yes. Continue.
Yeah, to know this problem. That's why I am here, doctor. I came for the investigations.
Okay, yeah, your worries are, I will say that being you are a mother and kind mother, your worries are genuine. But I will tell you this meningococcal bacteria, they are not contagious as the germs like common cold or flu germs. They spread through specific like sharing with the secretions from the throat or airways if the child is having this disease and if the people are having close contact with them. Are you getting my point?
Yes, doctor, but how can we know about the contact? The child was in same school. Maybe they came in contact while playing or something. You said the secretions from throat and
Yeah,
airways also. Maybe someone sneezed and he respire. We don't know, doctor. So the safest thing, my feeling is better to do for him some blood tests and also the scan of his brain to check whether this bug has entered his brain.
yes, you are right. We have examined Jack. He's completely fine and he don't have any symptoms that are regarding to the meningococcal this brain infections. I will tell you that people do not catch these bugs through casual contacts or breathing air where someone with meningococcal disease is having. Are you with me?
Yes, doctor. So, what is the solution now? I don't want my child to get this bug into his body. That's why I'm worried. And now, maybe
Yeah,
so what you will do? How you will prevent him from this?
well, if somebody is having this meningococcal disease, there are increased risk of getting sick. The people who are living in the same household or they are roommates, or if they have any direct contact with the patient's secretions from the mouth. So these are the people where we are giving some medicines. As in the case of Jack, I will tell you, he's not in the same class as the other child was having this condition, meningococcal disease. He was not in the same class. So this is very rare and very less likely that Jack is having the same uh, condition, and we need to give any anti-bug treatment for the Jack. Am I clear so far?
Yes, doctor. Now you said you about the antibug treatment. So now what you will not give us antibug treatment as well?
Well, Jack is having at the moment only this, as we are suspecting that he's having just common cold, and for that he needs to give uh, treatment like we can give paracetamol if he's having fever, and good hydration. That is the one thing that you will have to give a good fluid and good nutrition. And I will tell you, if any time he's getting any, like he's getting throwing out episodes, or he's drowsy, or he's not taking feed
6 minutes
properly.
finish.
Okay, he's not taking feed properly, so you can come back. Is that okay?
Yes. Oh, okay, doctor.
Or
But
if he's getting any rash on the body. Okay.
yes. So I will just observe him and bring back. This is what
Yeah.
I'm telling. But why?
Yes.
But why? I mean, see, by doing the blood tests or by doing the some means some scan of his brain, I don't think we will have any problem. We are on safer side because we will be sure that the child does not has anything. So why can't we go for it, even though you are thinking that
uh,
there's nothing?
Yes, Jen, I will appreciate your worries. Uh, all these tests which you are telling me, this will give another burden to the child and to you also and the family. He will have to take off from this from the nursery, and definitely these are the brain scan. Have to give medicine to keep him calm, like sleeping medicine. This will be give another stress to the child and to the family as well. So these are the rays, and the other tests definitely will have to take the blood. So this will give another stress to the child. Are you getting my point? And all these tests, as we know, this will going to become normal. So we are giving the stress to the child, and for a condition which he's not having.
Okay, doctor. Okay.
Okay, if yeah, if Janan, if you have any other worries and uh, or any other concern, I will be happy to address.
No, doctor, I don't have any concerns now.
Okay, so may I summarize what we have discussed today?
Yes, doctor.
So we have discussed about Jack condition, who's having a common cold at the moment, and as you are suspecting that may he has this meningococcal infections, as the one child, the same school he's having. So I told you that it to get this infection takes close and lengthy contact to be spread these bugs. So in this Jack condition, this is not the case. And as I told you, anytime if Jack is having throwing out episode, he's not taking well, looking very sick, or he's drowsy, or getting any eruptions of the rashes on the body, you can come back. And as I told you, all these tests will give another stress to the child. So there is no need at the moment for a condition which Jack is not having. So so
Time
I
Okay.
will
finish.
give you some leaflets also, and some study material you can get through. Okay, you can come back if you have anything. Thank you very much.
Okay, doctor, thank you so much. I think it was okay, but I will add some more points for you. So you asked about
Okay.
attender, it was good. You asked about previous knowledge, it was good. So regarding her worry now, she has two worries now. One is maybe her child will get meningococemia, so she wants investigations. Other worry is she wants some prophylaxis. Okay. So for the investigations, you told very nicely. I will add some more points. Like I always tell, whenever we see a child, we will always check benefits versus risk for any procedure on a child. Okay. We will always
Okay.
consider
Yeah.
for benefits versus risk for many procedures. Like for example, she was asking for imaging. You can say that the imaging is the imaging like CT scan or the scan of the brain. What we usually do is CT scan is 100 times more powerful than the normal x-rays. That means we are exposing the child to something which he does not need at the moment. Okay. This you can say, or
Mm-hmm.
if you don't want to tell 100, you can say multiple more times the radiation is higher than the normal x-ray. So I am unnecessarily exposing him at this moment when my examination of the child is not suggesting this. This can also be a point in many cases when they insist for CT brain, like
We are doing a CT scan, or we are doing MRI in meningococcal disease.
uh,
That is for me. I want to give this also. It was in my mind to give this exposure to radiations. But
yeah,
if
but
we are doing
MRI,
MRI, there will be no exposure.
MRI, it will be 20 minutes, and in small children, I'm not sure, do they means for urgent anything, they do CT or MRI. Anyways,
That's why I told that it will give the another stress, and he will have to take off from the
yeah.
school, and we'll have to give the medicine to keep him calm. So that is I was telling about the MRI. I don't know CT scan they are doing or not. I don't know. That is why I did not tell about the radiations
Okay, no
actually.
problem. Radiation is one in
So
any case.
sorry, CT or MRI, why you want to do?
Maybe some increased
Yeah.
intracranial pressure, sepsis, like this. The mother is asking here. You can also tell that there are some in investigations like putting a needle in the back, which is not needed at the moment. Okay, to diagnose. If he has the symptoms, then only we will go. And also sometimes when there is increased intracranial pressure, you will not go for these investigations.
No,
We will
we
do
are
only
not
plain
going.
CT. We will
Plain
do
city,
only plain CT.
plain city we can do, or CA, we
That
can do CSF analysis.
No, that's what I was
Yes,
telling. I was
CSF is
telling plain
diagnostic.
CT only. Dr. Adnan was the one who asked about MRI. I was telling
Okay,
about the
okay.
CT brain only because the mother can ask you about imaging. Any brain, they will think that imaging will solve the problem. This is the normal thinking of the people. Okay. So if she asks about
Okay,
imaging,
okay.
you can tell her that it is multiple more times stronger than the normal x-rays we do, and it will we are exposing the child to a thing which is not needed at the moment. Okay.
Yes,
This
yes.
is one
Okay.
explanation you can give for her. And you told very nicely about sleeping medicine. Maybe it depends upon the child. If he's not cooperative, you may need it. So this is for the brain scan. Other thing for the meningococemia, even though the child is in a higher class, you are not sure about the contact. As you say, your explanation is very good. Since the other child is in a higher class, maybe means maybe he is not in close contact with your child, but still as a matter of precaution, we can have a meeting with the school teacher or the school nurse to know about what exactly happened with that child, and with whom, means with which class students and all, by chance if there was any contact, and does your child really needs any supplementation with the anti-bug treatment at the moment, like this.
Actually, they have written in the indication for this meningococcal in the UK.
Mm,
They have written that if the people in the same household, or
mm.
they are sharing the rooms, or they have any direct contact with patient's oral secretions, these are the three indications where we are giving this prophylaxis.
Okay, yeah, I agree with you.
That is also good. Yeah, that is also good. We can say that if they have not given in the scenario, we can say that we will explore further and ask the school authorities who was the contact with the other child. So we can consider that further after asking the school authorities.
Yeah, that is one of the good options. I'm telling, we can tell strongly, your point was very good, that the child was in other class, less likely that there is a close contact with this child, but still.
Yeah, we can say like this.
uh,
Yeah, as your child, the child who has gotten this meningococcal disease, is another class, and we are giving this prophylaxis anti-bug treatment for the people who are in the same household or sharing the roommates, sharing the rooms or roommates, or they have, if they have any direct contact with the patient's secretions from the mouth. So we are giving these anti-bug treatment. So let's we will explore further from the school authorities, and
mm,
we will see if Jack required this anti-bug treatment or not.
yeah, like this,
Like
maybe
this we can.
sometimes what happens in the schools, there can be some means normal function, and there can be some mingling also, we cannot 100% say this. So now the secretions in the mouth can also be some like sneezing or anything as well, right?
Actually, they have written that people can spread this bacteria to other people by sharing the throat or respiratory secretion, that is saliva or spit by kissing, not by breathing. They have written clearly.
Not
I
by
don't
breathing.
know.
Okay.
Fortunately, they are not as contagious as the germs that cause common cold or flu.
Mm-hmm.
All these I have written in my notes. So I
Mm.
have taken these notes from UK guidelines.
Regret?
People don't catch bugs through casual contacts or by breathing air where someone with meningococcal disease has been.
Okay,
So
that
not
means
simple casual contact or breathing air.
I think what you are telling is right. They're expecting strongly to say no need for prophylaxis here. But also at the same
Yeah.
time, to save, we can also tell if you want, like maybe we will contact the school and know, was the child really in close contact with was the class with this class children, and do they really need, can be explored, and if needed can be provided, like this.
Yes. One question they ask, which you did not ask, they have asked about the other child. He's admitted in the hospital now. How is his condition and like this? So they want to breach the confidentiality. So we will not breach the
Of the same child,
confidentiality. We will not tell it.
no, of the same
Yeah,
child,
yeah, yeah, yeah.
same child.
Yeah, this scenario came recently in UK. The same scenario, at the end mother asked that, okay doctor, if you think that my child is okay, okay, no problem. So I just want to ask about this other child. He's admitted in the hospital, so how is he now? He will die or what will happen? Like this he was asking. So
Hmm.
for that you will say that uh, I'm really sorry to tell that we every patient is having his confidentiality, so we cannot breach the confidentiality here. So we cannot tell about the child condition at the moment. Simple word.
Okay.
Because this was the hidden agenda,
And
so you
also
cannot tell about the other
we
child.
cannot tell about the child unless there is permission from the parents also. So Means we will
Yes.
not disclose. And also we can add here, it is our hospital policy also, we can add like that.
Yeah. You can like this. This is our hospital policy, and we cannot disclose for other patients to anyone, and without permission from the parents.
Yeah.
So this at this was the complete scenario actually.
Mm. So what did you
And
talk to
the
anyone?
candidate also, yeah, candidate also said the same things which I have told you. The same thing. Mother was asking for the prophylaxis antibiotic,
Mm,
and for against the meningococcal prophylaxis. So
mm.
candidate same thing said that as he's not having the close contact, we are giving the antibiotic to the peoples who are living in the same rooms, or sharing the rooms, or they have household contacts, like one child is having this disease and the people living in the same house, we can give to them. Or if they have direct contact to the secretions from the mouth, we are giving only these medicines to those people. So
So
what
we
we
can
are giving the medicine, they may ask you, you know this one, yeah.
ciprofloxacin, right?
Yeah, ciprofloxacin for close contact meningococcal, only this one. Before they are giving rifampicin and others also, but now they have omit. I don't know in pregnant ladies, I think still ciprofloxacin we cannot give, so we'll have to go for rifampicin. But in the
Ceftriaxone,
guidelines,
ceftriaxone. No, no.
ceftriaxone,
For
sorry,
pregnant,
ceftriaxone.
yeah,
Yeah,
IM
but
ceftriaxone for
yeah,
pregnant and OCP taking kids.
yeah, but
OCP taking parents.
in the guidelines they have not written this one now. I don't know why. Not specifically mentioned for pregnant ladies, even not mentioned for ceftriaxone. They have mentioned only ciprofloxacin. And if the child is having Haemophilus influenza B virus and the age is less than 10 years, they are giving the rifampicin. That will be four
Rifampicin.
doses. Yeah, 4 doses OD for 4 days.
Allah, here it is written.
Ciprofloxacin is single dose, right?
Yeah, ciprofloxacin is a single dose. Ceftriaxone we are giving
Rifampicin
before
dose.
also, that was also a single dose, and we are giving the rifampicin, that is the 4 doses OD, yani once a day for 4 days. That is for the prophylaxis against Haemophilus influenza B.
I think pregnant lady, they will not ask us, so it's okay for us. Let's remember this ciprofloxacin and rifampicin, right?
Okay.
Okay.
So that's why I don't know this one.
In the patient info,
Hmm.
there is one, there is written, uh,
I
ciprofloxacin
I will
is
call I will call.
What call? You have a call? Okay, continue, Dr. Yasser.
It's written ciprofloxacin and rifampicin are both recommended by Public Health England, but ciprofloxacin is the preferred child for most individuals. Ciprofloxacin can be used in all ages and in pregnancy. It is easily available in a single dose and does not interfere with oral contraceptives. But it is contraindicated if there has been previous sensitivity. And
Okay.
rifampicin is no longer the drug of choice. Although it is licensed for chemoprophylaxis, it has several disadvantages, important drug interactions.
Mm. But I think rifampicin is mentioned for Haemophilus influenza in guidelines.
Yeah, but not for meningococemia, na?
Not for meningococemia, Haemophilus influenza is mentioned. So just we will remember ciprofloxacin single dose. That's it.
Yeah.
As prophylaxis to close contacts who are in the same households and who are roommates, or any patients whose secretions came in contact. Mouth secretions. What, Dr.
There are three things. Number one is in the same home that are sleeping and living with the patients.
Okay.
And second, having classmates. Third, girlfriend, boyfriend. Fourth is having living in universities or college that are sharing the same kitchen. And fourth one is droplets are secretion from the respiratory tract.
So droplets is also there here.
Yeah, yeah, yeah.
Okay. This is from patient info you are reading.
Yeah, yeah.
Can you just screenshot for me only this part and send, if you don't mind? Because again, I
I
will.
will send.
Okay, the same thing, same household, you said, roommates, you said, and girlfriend, boyfriend means this is the secretions contact, this is the problem. And this will be droplets. So one of the solution is also telling about checking for his going back and checking for if he really had any contact with the patient. Okay.
Yes, yes.
Okay.
Because here we can say because he has not in his class, so it's less likely.
Yeah, we can strongly say that it is less likely, but at the same time, we can say that we can go back to the school authorities and check if there was any time any close contact between these classes for any reason, so that we can consider prophylaxis for this child or for his classmates as well. Okay.
Okay.
Okay. You give me.
1 second.
No, I was telling about brain scan. In severe cases, if there is raised intracranial tension and reduced consciousness, GCS is less than 8, they will go for imaging, right?
To see what?
The infection in the brain, maybe the means any, I don't know, abscess or any, I don't know. They will not go for CT brain in these children. I think it's written in guidelines. I will check.
Alas, we will see, but the one we are doing
They
just
have
for
written
those.
clearly that whenever there is child indications for lumbar puncture and contraindications for lumbar puncture. In that, whenever there is,
What are the indication for CT scan?
I think one of this is raised intracranial hypertension with GCS less than 8 and also child consciousness level. I don't know about the new guidelines. New guidelines he has just given like this, but in the previous red book it is there. We can go back and check.
Yeah,
later.
yeah. I think age less than 8 years, GCSS less than 8, and there is GCSS drop 3 scale, 3 number from the previous one, and any local side problem or any bleeding disorders. Then we can go for CT or fundoscopy.
Okay. Okay, give me the case now.
Okay, this is a development station. Okay, so it's look like a clinical only examination.
Development station, what? What is the age of the child?
4-year-old John
Hmm.
do social milestone assessment of this child.
Only social?
Only social.
4-year-old John, social milestone assessment of this child. Okay, I'll just prepare my template and then we will start. Okay.
Okay, and I am not giving you the means you have to tell me in every what will be the age of the patient at the end.
No problem.
Okay.
Okay, good morning. This is Dr. Noor, one of the children's doctor in this hospital. After greeting the parents and mother of John, mother of John, I will start examining John. I will first observe him. What is he doing in the room? What is the observations? I can see anything.
Yeah, he's playing with his toys.
Playing with his toys. Okay. So I will try to communicate with John by calling John. John, how are you? Like this. Is he responding to me?
Yeah, but little bit. He looks you and then start playing again with the toys.
Okay. I will just look for eye to eye contact. Is he making eye to eye contact with me?
Little bit.
Is he is able to make, or he doesn't want to make eye to eye contact?
He doesn't want to make.
Okay, he doesn't want to look. Then I will check where I will just look whether he's well looking, not in distress. I want to check his weight, height, and head circumference and plot on the appropriate growth chart for age and sex.
All around 25th centile.
Okay, I want to look for any unusual face in the form of upward slant eyes, depressed nasal bridge, any low set ears, any unusual facial features I want to see in the face.
No,
No.
normal.
Okay. Then I want to look for anything he has brought in the surrounding, like wheelchair, walking stick, or is
No, nothing.
he attached to any, does he has any glasses and hearing aids?
No.
No. Okay. Now, after doing the general examination, I will start taking the social examination. Firstly, the child is playing, so I don't want to disturb him. I want to observe his playing. So I will see he's playing alone or he's mingling with someone to play.
He's playing alone.
He's playing alone. No one is around him. So we cannot say whether he is able to share the toys or not. So I will ask the mother, is he now he's 4 years old? Does he share toys with other children and does he plays with other children at home? I will ask the mother.
No.
No, he's isolated. Then I'll ask the mother also about in the home. Maybe I am a stranger. He doesn't want to do the eye to eye contact. So I'll ask the mother if he's doing eye to eye contact with her at home and also with other children in the school.
He's only having affection with the mother, affiliation with the mother, but not with other siblings.
Okay. So then I will ask about his toileting. I will ask the mother, is he dry by day? Or
No,
is in nappies? He's still in nappies?
he's in nappies.
He's still in nappies. I will ask if he wants to go for toilet, does he expresses his need?
No,
No. Okay. Then I will ask about dressing. Does he dresses by himself?
no.
Does he helps her to undress? Does he helps her to dress him or no?
Yeah, mother helps him to dress and undress.
No. Will he help when the mother is dressing him? Will he give the hand like this or no?
No,
No, he's not helping. Okay. Then I will ask whether he can wear the shoes and remove shoes and socks. Wear and remove shoes and socks.
yes,
He can
yeah,
do.
he can.
Okay. Then I will ask about the feeding. Can he use spoon, fork, and knife together and eat?
No,
No. Okay. Then I want to check. Can he use the fork alone?
no,
No. Okay. Can he drink with spoon and can he use cup and spoon?
yes.
Yes. Okay. Then I will. So I want to ask about washing. Does he knows to wash his hands?
No.
No. Okay. So I think I am done with the social. And also I
Okay.
ask
What other things you want to ask in history, or what other things you want to do?
I want to ask the mother about how is he communicating with her. Is he using some words to communicate, or is he pointing if he needs anything? If he's pointing, or if he's taking her to that point to show that he needs that, I will ask that. I
Okay.
ask about that, and also I want to ask about his language development. How has he developed his language? And are they using one or more languages at the home? Okay, and I want to ask if he has a school, if he has been put into the school, and how is he doing in the school, and any complaints from the school.
Okay. So describe your findings.
So today I examined 4-year-old John for social development. With my on my examination, John on calling is not having any eye-to-eye contact, and I inquired the mother even at home. He has only attraction to the mother but not to other siblings. He prefers to, he's 4 years old, but does not share toys, and prefers to play alone most of the time. Prefers to play alone. And he is still not dry by day and still on nappies, and does not express his needs to go to the toilet. He can use cup and spoon for feeding, but not fork. And he does not help in dressing or undressing.
Okay. So what will be the ages in
So
perspective corresponding domains?
with these findings, I think John has an age of, in the social development, age around 18 months.
How?
John is around 18 months because he is able to use cup and spoon in feeding, but not fork. And
Okay.
he does not share toys and plays alone. And also he's not toilet train. He is not dry by day, and does not expresses his needs. And also he does not helps in dressing and undressing. So I will give him the age of 1 year to 18 months.
Okay. So regarding his playing, what age you want to give him?
Playing alone will be 18 months. Solitary play is
How?
18 months. Solitary play is 18 months.
Solitary play is 3 year or 18 months?
18 months solitary play.
18 months is only symbolic.
No.
Triple S is coming in the solitary. Solitary, symbolic, and 1S is what?
18 months is 3 plays. One is symbolic, one is solitary, another is spectator. These 3 plays,
Spectator,
all
yeah.
3 yes is for 1.5 years. Maybe he's playing alone, or maybe he will do a symbolic play like feeding a doll, or maybe he's spectator, means just watching the play. This is for 18 months, and I think there is something called PIP. PIP is pretend play, imaginary play, and parallel play. This is for 3 years. 2.5 to 3 years.
3 years, yes.
2.5 to 3 years. Above 3 years, they should share their toys, and they start group plays above 3 years.
Sharing toys, group play, and role play.
In group
These
play
are
also
coming.
there
This
is like
role player is 6 year. Group
Yeah, role
player
play is 6 year.
5 year.
Group,
Toy sharing is 4 year.
yes, 4 or 4.5 years toy sharing. So
you
this is kind
see,
GFR.
Toy sharing is given today. I saw in that MRCPCH one page is there, no? In that he has given 3 years. So for toy sharing, better keep more than 3 years, like 3.5 to 4 years. They start sharing toys. Below your crude estimation is less than 3 years. They are usually
Yes, you are
playing
right.
alone and not sharing. This is less than more than 3
I will tell you, just I have opened this.
Yeah.
Yeah, Dr. Noor,
Huh?
share twice is 3 year or 3.5 years.
Yeah.
Share twice. Then is coming GFR. G for group play is coming 4.5 to 5 years. Fantasy play is coming 5 years, and role play is coming at 6 years, 5 to 6 years. GFR. So this is triple S PIP GFR.
Group play is 4.5 years, fantasy play is 5 years, and role play. This is like they are going up, up, up. Here, what happens? Group play is they are making groups and they have and they play. And I think by 5 years, or something, they prefer to play in the same gender. They don't want to play with other gender. That is also there. I think 4 years they
Yes.
will intermingle, but as they grow 5 years, they prefer to play with the same gender.
Okay. So suppose this you consider he is a socially 18 month. So what will be the causes?
I want
This is the main
I
point.
want to send this. I want to do the observation of this child to rule out autism in him, because there is no good eye-to-eye contact in this child. Maybe
Okay, number one.
autism
Number
is
two.
cause. So, and also I want to autism can be due to many reasons, including genetic. So I want to do head-to-toe examination of the child to see if there is any genetic causes supporting his cause for this.
Now, autism is also a genetic disorder.
No. Sometimes it comes without the genetic, just behavior also. Not that every child will have genetic.
There are different factors that can cause the autism. One is the genetic, one is the environmental, the third is some behavioral issues, or it can be associated with syndromes. So all these are the things which
Yeah.
can
So
contribute to
whenever,
the autistic spectrum disorder.
So whenever whenever we observe that whenever we suspect that the child has autism, then this child will be sent for child developmental center for evaluation by the autistic spectrum disorder team. This is a team of doctors who are neurologist, child psychologist, and psychiatrist, and a pediatrician, and also they will have physiotherapist, occupational therapist. This is a team. They will evaluate the child based on the DSM-5 criteria or ICD-11 for I think more than 6 symptoms in their 3 domains. There are 3 domains in autism. More than 6 symptoms in each domain will be observed in 2 settings, and then they will diagnose. This is how the autism is diagnosed.
Can you repeat the team again? Sorry.
Autism, whenever you have a suspicion of autism, maybe the mother, the teachers, or whoever, so there are 2 options. He can be referred to neurologist for evaluation, or the GP can refer him to the child developmental center. In the child developmental center, he will be evaluated by the autistic spectrum disorder team, ASD team. Okay, this team is a group of doctors like pediatrician, neurologist, occupational, mainly you have to tell the medical doctors first: neurologist, pediatrician, child psychologist, child psychiatrist. Then also they will have occupational therapist, social worker, physiotherapist, all these things.
No. Malish. Sorry. If the child is less than 5 years, he go to the child development center. If he is more than 5 years, he will go to this autistic spectrum this assessment center.
But
and there is no need for neurology.
No, what I'm telling is from patient info. I read and made notes from patient info. It is given in patient info.
Okay, I will check because I don't think the neurologists have any role here.
No, there is a role. This is ASD team. If you don't want to tell, you have to tell ASD team, but you should mention.
No. I am
Here.
first there is a team to assess the patient. There are two this autistic spectrum this specialist. One is staff nurse, and they examine it on once in school, once in home, and just like this one. Then they will meet, and then they will finalize that this patient is autistic or not.
Let me share you now only. It will just take 2 minutes only. Autistic spectrum disorders. I just read from there and made the notes because they are asking how do you diagnose autism in the exam. Okay, so I will show you now the diagnosis here. You're telling neurologist will not come in the team, but here it is mentioned neurologist in the team. How autistic spectrum disorders are diagnosed. Let me see if this is 1 minute. This is not for medical.
What happened?
Okay, now here specialist diagnosis is required. This is probably best done by pediatric neurologist, developmental and behavioral pediatricians, child psychiatrist and psychologist. Ideally, there should be a multidisciplinary team, the ASD team, with specific training and experience in evaluating the ASD. So this is the ASD team he has mentioned. That is the pediatric neurologist, behavioral pediatricians, child psychiatrists, and psychologists. Then I went to the NICE guidelines and I checked what is the ASD team. Then I wrote in my notes. The ASD team consists of mainly child psychiatrist, there will be a pediatrician, then child psychiatrist, child psychologist, and also the additional members here will be neurologist and also the occupational therapist, physiotherapist. They are all additional, but main will be 3: pediatrician, child psychiatrist, and psychologist. So they all form a team. We have to mention them. Neurologist is here. Okay, and even if you read further, they have given they have given about these 2 criteria. They are diagnosed by this DMS-5 or ICD-11 criteria, observing the child in 2 settings for more than 6 points or 6 symptoms in each domain of autism. Okay. What are the domains of autism now? What are the 3 domains of autism? Hello?
First
One
is
is behavioral.
interaction. Mhm.
Okay, continue.
No, continue. I have no idea. Before I remember, then I forgot.
Social.
One social, one is behavior, one is linguistic.
Yeah, there are this you can consider as verbal and non-verbal in social. And another is the behavioral.
Yes.
Yeah, this is how you have to answer. You means I don't know about the age less than 5 years, more than 5 years, but someone who is a pediatrician practicing in UK, they told me he is a community pediatrician practicing in UK. Any child suspected of autism will be first referred to child developmental center. Okay. And then from there, I added this ASD team from the patient info. Okay.
Can you share this team in the group if you have this?
Yeah, I wrote in my notes. I will take the picture and send. I then went to
Okay.
NICE guidelines and wrote this team.
Yeah,
In
please
the
share
NICE
this one.
guidelines. And
Actually, this
yeah,
one is social interaction. First is the domain. I have written notes also. Social interaction, that will be of solitary play, no social response, no emotional response, and tantrum. This is our the social interaction. So it will be S set. I am remembering this S set. S means solitary play. S is social response. E is emotional response. There will be no. So tantrum. Then is coming behavior. Behavior is coming like rigid and repetitive behavior. Then coming obsessed with one toy, obsessed with one part of toy, and stimmering. Stimmering means repetitive movements and sounds. So this is coming under the name ROS. ROOS. Rigid, repetitive. Obsessed with one toy, obsessed with one part of toy, and stimmering. Then is coming verbal. Verbal is delayed speech, echolalia, scripting, and conversation that is not active conversation means conversation not active. So this is coming under desk, DESC. Then is coming non-verbal. Non-verbal is spin, pointing response, that will be limited. They cannot point towards anything, that will be limited. Eye contact, limited. Expressions of the face, limited. Needs, they they cannot show properly, that will be also. So all the things will be non-verbal, will be limited. All the things pointing towards anything, limited. uh, Eye contact, limited. Expressions, limited. Needs, limited. So all the things will be limited. These are the 16 points. From there they are taking all these 6 points or something.
yeah.
From these are the 16 points actually.
Just we have to remember this: the 2 major diagnostic classification systems in use are this ICD-11 and Diagnostic and Statistical Manual of DSM-5. We can say like that. If they ask, we can tell the full form. Then what they are doing is they are recording 6 symptoms. It's mentioned here in the forward. Somewhere they have mentioned that they will record 6 symptoms in 2 different settings. If it is there, then they will diagnose as autism, and then they will further manage the child under ASD team. But before that, along with these things, a detailed examination of the child to rule out any suspicion of genetic disorders, neurocutaneous syndromes, all these things has to be done. That's why here comes the neurologist also. The neurocutaneous syndrome, especially the tuberous sclerosis, they want to exclude. Okay, and any other genetic conditions. So the complete evaluation of the child to rule out genetic conditions has to also should be done. Just go through this, you will get to know about the diagnosis. But he hasn't mentioned child developmental center. It was told that routinely they will send. I am not sure. Okay, this if child is just shy with the strangers and he's very good at home with the brothers, sisters, and mother, but the autism child will be usually the same even at home, as long as he's not given the therapy.
Okay, and what
So
will be the other
the
differential in social?
the development of speech will also be good and normal, appropriate to the age, if he is growing well with his siblings. But we we see delay in the speech also in the autistic children.
Okay, this is my general question.
Hmm.
That what are the differential will come in having this social interaction, lack of social interaction except autism.
Selective mutism.
Mhm.
This is what I can give. Selective mutism.
Okay, I will see, no problem.
Okay, if you have, tell me.
I will check.
No, do you have any? No, did you have a? Do you have answer for this, or you just asked me?
No, no, I'm just asking you. Maybe I have, I will check. Because at least 1 month ago we did all of these. So I will check. Is there anything?
Okay, no problem. Okay, we can go for the next now. So you want to do now video, Dr. Yasser?
Okay.
Okay, this is 1 month old child in the emergency setting. Okay, describe the findings and then give your history, examination, differential diagnosis, and management plan for this child. Okay, I will give you 2 minutes. You can prepare and then we will start. So we can start.
Yes, we can.
Okay, describe your findings. This is a 1 month old child.
Yeah, I have seen 1 month old child laying in a hospital setting. Looks to be well grown, but I would take length and weight and plot on the centile chart. And he's not looking dysmorphic. He has all of the skin. There is a peeling of the skin, mostly in the flexure area, and especially also there is a denuded skin in the groin and in the pubic area, and there is pussy discharge from the eye, and also look like a oral thrush.
Okay.
And there are some yellowish patches over the scalp and over the left arm and hand also.
So what is the history you want to take in this child?
I will take history for onset, duration, aggravating, relieving factor, any history of
And
fever, any history of cough.
anyone is keeping the time or no? Okay, let's start from
I will keep. I will keep. No problem. Just 1 minute left.
okay, start
Clock.
from the
No problem.
history.
Continue.
Okay, onset, duration, aggravating, relieving factor, any history of fever, cough, seizure, loss of consciousness, and any joint swelling, any poor oral intake, any contact with any person, and any family history, any history of drug intake.
Rhoda, what he's saying, father?
So my differential could be, then I will like to do examination involving the whole of the skin, chest, joint, and CNS for any sign of meningitis or raised ICP, anterior fontanel joint for any septic arthritis or osteomyelitis, chest for pneumonia, and skin for any boil or any cellulitis. And in the investigation, I will do complete blood count, CRP, ESR, blood culture, and then send specific for send the skin.
Differential diagnosis first.
Okay. And also in the examination, I will do Nichols sign.
Okay. Nichols sign.
Okay. In differential could be Staphylococcus skin scalded syndrome, could be 10, could be Steven Johnson, and could be drug rash, and could be pemphigus.
Okay, drug rash.
Okay.
This comes under 10 and SJ, yes. Any other drug rash you are telling?
Drug rash, any drug rash will come.
Okay. Okay. Then what else?
This Steven Johnson.
Okay.
And then pemphigus.
What is the investigations you want to do?
I want to take them some supportive and then specific in the supportive. I want to take complete blood count, CRP, ESR, and blood culture. In specific, I want to take the swab from the site to see for culture sensitivity. Then I will
Swab
take.
From where you want to take? You want to take swab from
the skin, from the nuded area.
From the skin. Okay. Okay, then.
The peeling area of the skin.
Then.
And also I can take the skin biopsy to look for organism, and also I can take nasal axillary umbilical swab for culture sensitivity for to rule out the source of infection. And if spike fever, then I will take blood culture and acute phase reactants.
Okay, so management, what's your management for this child?
Management of this child is mostly supportive. In specific, we can use oral flucloxacillin or IV flucloxacillin. But in supportive, we have to keep.
You will consider oral or IV. The child is 1 month old.
IV is the preferred one.
Okay. Then.
Okay. Then we will in the supportive. We have to correct dehydration, electrolyte imbalance, any hypoglycemia, and then we have to apply to keep the skin moist by applying emollients all over the skin. Take daily bath and gentle care of the skin. And if it's involved more than 50%, we can involve burn unit for further management.
If more than 50%. Okay. So tell me about prognosis in these children.
Prognosis is good. Prognosis is good. Although they can having cause of death in the form of septic shock, but it's very involving septic arthritis, pneumonia, meningitis. But prognosis is good, and those who are not presenting late to the hospital setting.
Okay.
Continue, time over.
Early diagnosis and management.
Yeah, early diagnosis management.
Okay, I think you finished. You covered good points. In the history, you asked onset, duration, and progression. You asked for fever, which is very important. Maybe cough, shortness of breath. You are asking for the pneumonia. Then for the sepsis, CNS involvement, loss of consciousness. Feeding is very important in this age children, and activity is also very important. I think you asked for activity as well, right? Because for the sepsis, hypotonia and not good activity will give us sepsis. Contact was asked. Family history, in particularly, you will ask for what? Family history of what?
That means any other person has this disease, means in the, yeah, you can say it will cover in, it also cover in contact also. So
No, family history of epidermolysis bullosa is important here for your differential diagnosis.
yeah.
Okay, family history.
Yeah,
Okay,
you are right.
you told contact that came there, but here family history of epidermolysis bullosa is very important for your differential diagnosis. Okay, then in examination, very well said, the whole skin examination you will do, including Nikolsky's sign, to see the suppression of the epidermis. Then joint, any joints involvement, CNS for meningitis, and RS you said for pneumonia, right?
Yes.
Any other thing we can consider? I don't know. Okay, then
Joint examination for septic arthritis or osteomyelitis.
okay. Then you told Staphylococcus aureus skin syndrome, 10 SJS. Other
Vitals,
important here is the
vitals tell about the vitals. For examination, you will take the heart rate, respiratory,
Yeah,
etc.
you are right. Vitals.
we will say
CRT.
vitals both here in examination and management, both.
Yeah, either where you want to tell, but you will have to tell about the
No,
vitals,
the vitals are part and parcel of examination. First
and
of
you
all,
will have to tell
actually in
about the
videos,
capillary
there
refill
are
time also.
three things: vitals, anthropometric measurements, and if he or she is pubertal age, means more than 8 or 9, we have to say Tanner staging.
Okay, okay, but at least in one place mentioned, don't forget. Okay, so
Yeah.
other things you missed was bullous impetigo and
Yeah, I told that.
epidermolysis bullosa.
Mainly,
These two things you forgot.
mainly hair. Yeah, mainly hair will be differential. First is tetras, Staphylococcus aureus skin syndrome, and the second should be kept 10. 10 is toxic epidermal necrolysis. Then you should keep not here this Steven Johnson. Better to keep epidermolysis bullosa.
Yeah.
I think
Because
so.
his eyes and
Age,
oral cavity is involved, so that's the reason I am saying.
yeah, Steven Johnson also will keep. But why I'm saying this is just 1 year old only. That's why I was thinking. In the
Yeah, you
history
are right.
points, you have covered very rightly. Onset, course, duration, progression, history of fever, and to check the source of the infection for the CNS infection, like throwing out episodes or any drowsiness, and you will have to ask about the any respiratory distress, any cough, any joint swellings. Joint pain he cannot tell, so joint swellings. Then you will
Yeah.
say about the about this is the source of infection. Then the history of any drug taking, any medicine taking, not drug, sorry, drug is not a good word. So history of any previously medicine, any medicine he is taking, family history to rule out for the epidermolysis bullosa. Then you will have to tell about in the history which I was forgetting. No, just it was in my mind. Medicine, and yeah, these are the main thing which I'm getting now.
But for one
So
month old, what drug you are expecting here? 1 month old. Means
previous, if he was coming, yeah, eyes is involved, maybe he was taking some like which drugs can cause this Steven Johnson, this one, I think clarithromycin, microlides, which macrolides can cause
penicillins can cause sulfa, sorry,
sulfa
this
drugs also.
trimethoprim and sulfamethoxazole.
Yeah,
Bactrim.
yes,
Ceftra.
this is
But here less likely
Ceftron.
to give all these things to the small child. So you can keep it drug induced, but less likely. But here you have to keep
Less likely. That's why I said,
causes.
see,
Infectious
yeah,
causes you have to
yeah.
keep there. Even the toxic epidermal
Infectious causes is the first.
TEN can
Yes,
even
yes.
come
You
with
will.
infections like herpes simplex virus,
Yeah.
hepatitis, influenza can also cause. Streptococci can also cause. So here you can keep infectious causes more than the drug induced. And also, what about the investigations? I asked him, skin. Are we taking swab from the skin? Or are we taking swab from primary infection for
See
the
here, Dr. Yasser.
Both.
No, Dr. Yasser said very rightly. You have to tell first CBC, CRP, and blood cultures, and you will take the serum electrolytes. You will take the RFTs as well, because childs may get into septic shock, and that can be to the renal failures or something like this. So then you will come to the swab from the skin, the first. Then you will have to swab from the nose and
Axilla.
from the throat and axilla to rule out the staphylococcus.
Focus.
Yeah,
but
staphylococcus
the
of the
skin
skin.
lesions here, are mostly caused by the toxins, not by the bacteria. So the skin swab
But still,
will
they
not
are taking the
do.
swab also.
The primary swabs from the nose, from the throat and axillary and maybe even umbilicus will help you. But the skin swab,
Not from
No,
the
this,
throat, doctor.
sorry,
Not from the
Malish.
throat. It is from the nose, axilla, and groin.
Axilla and groin. Okay, not throat.
Yes,
Okay.
it's not from the throat.
yeah, but what
Nose,
about
axilla, and groin.
nose, axilla and groin? But what about this, Rehana? They are taking from the skin?
Right.
Yes,
Not
No,
taking
they are
yeah,
taking
yeah.
from
They are
the
taking
skin.
from the skin. From the
for
skin.
culture and
Nasal skin.
sensitivity?
Uh-huh.
I will check and send you back, because for me, because skin eruptions is caused by the toxins, not by the bacteria.
Yeah, the one here is caused by the toxin, exotoxins.
Yeah,
But
so
the one we are checking screening, we are checking from axilla, nose, and groin MRSA. You will check that whether baby has MRSA, methyl and this resistant staphylococcus aureus.
Actually, that we are doing for carrier statics.
Yes,
Screening for
carrier
carrier
to
status.
see whether he's a carrying this stuff, carrier, as Dr. Yasir said, to see the carrier is.
The blister.
He's already.
Dr. Noor, I think so. You are talking about the blisters. The blisters
Yeah.
are negative.
that is why I am telling you,
Yeah.
skin
Skin
swab.
culture they have written. Skin culture in 10 they have written here. I'm just checking. This
Not
is the
for
health
the I
online.
am talking about staphylococcal scalded skin syndrome. Usually from the lesions like this exfoliated lesions here, they will not take from here.
If you take they will take from the, if you want to do the culture, you will do from the skin.
Yeah, no, I am telling you, from these lesions, they will not give you any culture. You have to take from nose or from the axilla or even from the groin. But the skin, this separated skin will not give
No,
you.
you will not do the separated skin culture. You will do biopsy.
Yeah, they will ask you this question.
Mm.
We will take
Yes.
the swab
Yeah, this from the skin,
You say no.
swab, from the, no, you will do skin scrap, by
Yeah,
skin scrap, you will
Dr.
do the
Noor,
biopsy.
Dr. Noor, I am looking here now in Dermanet. This is very famous, authenticated.
Yes,
They are saying that
from Dermanet,
history and physical examination. Then you will take the skin biopsy, which shows the intraepidermal cleavage at the granular layer. Then you will take the bacterial culture from skin, blood, urine, umbilical cord sample in a newborn baby.
Yeah, skin I agree with you, but skin not from this exfoliated skin. maybe from the axilla, groin, like this, because the exfoliated skin will not show you any bacterial growth. This is what I'm telling you. Can
In
check.
biopsy they have written, and this one is written Zank smear. Zank smear you are taking.
Yeah, biopsy is to differentiate between staphylococcal scalded skin syndrome and 10. You're doing it to differentiate between these two. What is the difference between how the biopsy will differentiate? What is the difference, Dr. Yasser?
Wallahi, there is linear of cleavage. I forgot
Yeah.
regarding this.
Cleavage here in 10, what happens? It involves the whole of the epidermis. But staphylococcal scalded skin syndrome will involve only part of the epidermis. Okay, that's why the biopsy will help you to differentiate between these two conditions. Okay, regarding
Dr. Noor,
the
regarding your question, it's written in patient info. The superficial blisters are generally culture negative, but Staph aureus is usually grown from the material obtained from the suspected site of infection, which could be umbilicus, conjunctiva, breast, surgical wound, nasopharynx, and occasionally especially in adults, blood.
that is what I was telling you. If you say the cultures,
Yeah.
from the culture from the primary site of infection, not from the blisters. You have to mention this particularly to tell the examiner that these blisters are from the toxins. We don't get the organism from these blisters.
Because here, if you do the culture, it will be sterile. It will show you nothing.
Yeah, so you will
If we take aspirate.
I will do culture from primary source of infection. That may be as you listed. List again, nose. What else? Nose.
Nasopharynx, no nose. Nasopharynx, surgical
Nasopharynx.
wound,
Nasopharynx, umbilicus,
conjunctiva,
and
breast, or
Okay.
blood.
Skin from anywhere, like nasopharynx is inside of, then the skin is umbilicus, then the axilla and the genitalia, anywhere from groins.
So in the management, the missed points, I think you told, I wrote here, but I don't know you told or not. Airway, breathing, circulation, vital signs, capillary refill time, very important. Hydration of the patient. And then you will consider antibiotics. Very well said about flucloxacillin. But what about the analgesia? What analgesia you want to consider in these patients?
We can give
Yeah.
paracetamol or morphine.
Okay, paracetamol.
And avoid NSAIDs.
Why you
Opioid.
want to avoid NSAID?
Because there are issue with renal and dehydration, renal compromise and dehydration, and NSAID aggravate that.
Yeah, one is the renal excretion of these exotoxins, and also as you said, there can also be bleeding in the skin, which might be aggravated.
And third is bleeding, and third is bleeding because NSAID, aggravate bleeding.
So
Platelet dysfunction.
One is the bleeding, one is the renal compromise. What else you said? The third one?
Bleeding.
No, before that, renal and okay, one more thing.
Mainly this one only.
Okay, bleeding and
Mainly NSAIDs are nephrotoxic, or they are it can cause bleeding.
yeah. Another thing is
These are
the
the two things.
physiotherapy. You want to also consider physiotherapy in these children. Why? What is the reason?
Yeah. Because they involve the flexure areas, and there are chances to develop a contracture or atrophy.
Yes. So this is the
Disuse atrophy.
So this is very important. Only they can one or two questions about Steven Johnson's. What is the difference between 10 and Steven Johnson's?
There are
10 is
area
severe,
in the
10 is the
involvement
severe
of
form.
area.
10 is the severe form of Steven Johnson syndrome, basically.
Yeah.
So this is the involvement of the surface area. If involvement is more than 30%, then it is called 10.
10. Yes, Steven Johnson's is less than 10%. In between 10 to 30, it is overlapping.
I don't know what is that.
It is overlapping.
Overlapping condition.
Steven Johnson and
More than 30. More than 30 is 10.
so the causes
More
for
than 30 is called.
okay, let me write. The causes for Steven Johnson's you can consider here as
See, there drugs, medicines. Then is coming some diseases which can cause like sarcoidosis and I think amyloidosis, tuberculosis. Then is coming this herpes infections.
yes, as you said, in virus you have herpes, AIDS, Coxsackie, influenza. Then in bacterial group A beta hemolytic streptococcus. Then
Yes,
mycobacteria, mycoplasma also you can consider common. Then for drug induced is penicillins and sulfa in antibiotics. And
sulfur. Yeah,
anticonvulsants also will cause phenytoin, carbamazepine, lamotrigine,
anytime carbamazepine, yeah,
and allopurinol.
lamotrigine, yes,
And
yes.
that's all. So you can give this as the but for me in this small child I think we have to put mainly infectious causes more than the drug unless he has received any drug like penicillin or sulfa. Okay, that's all. So we will go for the next case now.
Who is going to do next?
About this epidermolysis bullosa, it will present in the severe form, the familial, this one. You have any?
Yeah, epiderm.
Epidermolysis has 6 or 7 types.
Mm.
There are very severe forms who present with deformities. And the one we are looking, it's autosomal recessive, I think so. The very common that small children are present.
Okay, so for the SSS, always say I will take the swab from primary site of infection. Then list the primary sites of infections. And say the swab will not help from the site of blisters, but I will consider biopsy, skin biopsy from the site of blisters. Okay, to differentiate between 10 and staphylococcal scalded skin syndrome. Okay.
Give the time.
Okay. 6 and 3, yeah.
Yes. Good morning.
Good morning.
Hi Gina, how are you doing in our unit?
Thank you, doctor. I'm fine.
I am
Yeah,
happy.
it's going very nice.
I am happy to see you here and thank you for coming and nice to meet you. You know me, right? This is Dr. Noor with you.
Yes, Doctor Noor. Yeah, I know you. Yes,
Yeah,
doctor.
that's great. So let's start. I got to know that you want to discuss about some patient or case with me. Can you tell me what is your?
Yes, doctor. Yeah, yes. Today we have seen this, and my senior are saying that he's having neurofibromatosis. So I don't know about this. I want to know about what is neurofibromatosis.
I really appreciate your keen interest in knowing about neurofibromatosis. But before that, I want to ask, do you want any of your colleagues to attend this session with us?
No, doctor. Everybody is busy with his with their work, so you can start.
Okay, it's okay, no problem. So can you tell me what do you know about this condition? Any notes you have read or anything you know about neurofibromatosis?
Yes, well, doctor, I have just go through this Google. I search there. This is some autosomal dominant condition, and it affects mainly the skin and some nervous system. So I think this is only I knew.
Oh, you have given me a very nice and very relevant information. uh, that this will affect, you told me very good points. You told me that this will affect central nervous system and the skin. That's why this is also known as neurocutaneous syndrome. It is one of the types of neurocutaneous. Neuro means the CNS affection and cutaneous means skin affection. Okay, very good.
So, doctor, what may be the what may be the features where we can label that this child may have neurofibromatosis?
Yes, very good question. Any child, when you see the neurofibromatosis, the first thing what you will do is you will check for the family members. Okay, if anyone has
Okay.
in the family. So for diagnosis, we will do this diagnosis clinically by examining the child. Okay, to start with, first thing, as I told you, you will ask for any family member, close member, like the mother or the father has this neurofibromatosis. Okay, this is first degree.
Okay.
Then you will also ask about, see the conditions as the name neurofibromatosis. So you will have fibromas in the nerves all over body, you know, swellings. So you will check for these
Okay.
swelling, and sometimes it can be very big, large. It is, we call it as plexiform.
Okay.
You will check for that. Do you know, have you heard about cafe au lait spots?
Yeah, this one I know, doctor. This is like a coffee ground color. Uh,
Very good.
this spots on the skin. Yeah.
Yeah, it is coffee with milk. It looks like coffee with milk. That's why it is called cafe au lait spots. We will see the number of cafe au lait spots on the child's body. Okay, and again it depends whether the child
Mhm.
is small or big. That is prepubertal or postpubertal. If he is prepubertal,
Okay.
also we will see the size. It should be less than 5 millimeters in size, and if it is post-pubertal, it should be more than 15 millimeters, and it should be more than 6. We will count. We have all these things, you know, the criterias, many criterias, maybe 6
So
or 7.
other any other things we will have to look for, or only these only?
No, you will also have to look into the eyes, you know, any eye findings, you know.
Uh, some maybe gliomas.
Yes, very good. Optic gliomas, these are the tumors in the eye. They can go, sometimes the eye can be protruded, you know, or sometimes there can be
Uh-huh.
compression and also blindness in the eye. And also you see some small nodules in the eye, which you may not appreciate by your, he may need an ophthalmological evaluation with the eye doctor for to see in the slit lamp, you know, like this. So we are
Uh-huh.
keeping all this. There is list. I will give you my notes as well as the trusted websites to make the points
So
about.
doctor, it affecting the bone also, or just skin and CNS?
No, it, yes, very good question. It is affecting the bone as well. So there is, you know, the sphenoid bone in our face. Do you know that?
Yeah, yeah. This is around
Is
the
causing
eyes.
also, it can cause, so there can be some facial asymmetry in them due to the affection in this bone, and it can affect the long bones of the legs, causing bowing, and also sometimes artificial joints, we call them as pseudoarthrosis. It affects bones
So
as well.
doctor,
Yes, good
what may
observation.
be the complications? What may be the complications regarding that?
Yes, very good question. They can have many tumors in the brain. Okay, so the brain tumors can cause headache, vomiting. Okay, and there can be due to the brain tumors.
Only
Yeah,
only brain tumors or
no,
any other
no.
tumors?
As I told you, all over the body, they can have tumors in the eyes, which can cause this blindness in the eyes as well. And there can be ear problems due to tumors in the, this region.
6 minutes finish.
Um,
Okay.
this angle, I forgot what is this angle. Okay, they can
Okay.
have
Leave that.
so they can have many tumors which can cause lots of problems. Yes, and also in the skin they can have neurofibromas which can
So
come.
doctor, yeah, how we can manage
Yes,
these
as I
childs?
told
Any
you, this is a,
specific management treatment?
yes, very good. As I told you, this is a neurocutaneous disorder and it needs a multidisciplinary team management. One doctor uh, is not sufficient for the management of this. So we will first, our consultant pediatrician will be there, and we will involve the neurologist. As I told you, they will have brain tumors. Okay. And then they will have orthopedic problems in the joints, in the limbs. So they will have bone deformities walking. So we may need orthopedician, and also for any special shoes, orthotics may be needed. Dermatologist also, they may have this, as I told you, the problems in the skin and also the fibromas. And then they may need
Okay,
the
okay.
exercise. So physiotherapist, occupational therapist is also needed. And
Thank you
because
very
of
much.
so
Okay.
many problems, they may have psychiatric issues as well. So we may need psychiatrist like this. So this is a whole team
Okay, thank
management.
you, doctor. Yeah,
Okay,
thank you.
it was very nice speaking to you, Gina, actually. So I will give you some notes and some trusted websites related to neurofibromatosis. You can read it and do a seminar for your friends. How do you think about it?
Okay, doctor, no problem. I will do.
Okay, let me to summarize. Today we discussed about neurofibromatosis. It is a neurocutaneous condition causing several problems in the central nervous system, skin, and also bones. So we discussed how to diagnose it and how to manage it. Thank you, Gina. It was
Okay,
really nice.
thank you very much. Yes. Yeah, that was good. You have given all the information. Just for tumors, you can consider of that not only the brain tumors, there are peripheral tumors are also there, like pheochromocytomas, thyroid carcinomas, or Wilms tumors, very famous.
Uh,
And once you have used the word no, 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 don't use the word. They don't like this. No, no. So
no
especially in
means
our
what?
this.
What? No, I did not understand you. What? No.
No, no. I was asking you something, and you said no, no, not like this. So they are saying
Okay,
that don't use the word no in conversation.
okay, okay.
And yeah, that one I asked you about apart from the skin and this can be sphenoid dysplasias, which you have told, or this
Super.
pseudoarthrosis, which you have told.
And also
But
bowing, TBS
uh,
bowing.
yeah, this one, yeah, you should tell that tibial bowing or this kyphoscoliosis, it can affect the back also, and it can affect the bones anywhere, especially for the tibial bones.
I
Okay,
told, maybe
so
not here, tibial bowing I told. Then I told pseudoarthrosis, but I
yeah,
did not tell kyphoscoliosis.
for the management is like especially never ever forget about the plastic surgeon, which you did not tell,
And also
and they have
genetic.
problem with the child speech and language problem. So we need the speech and language therapist. We need the educational psychologist, especially, and we need geneticist because this is genetic condition, as you told in the beginning. So put geneticist, counseling, and they have problems with the sometimes hearing problems, audiologist, and they have some problem like pheochromocytoma, Wilms tumors. So these endocrinologist you'll have to involve,
Just
and
also.
ophthalmologist,
Okay. I wrote here.
orthopedics, and others. They are coming late. They are coming in the late form. Initially, you will have to involve the ophthalmologist, initially endocrinologist to rule out any tumors, a radiologist for the good imaging. Then you will have to involve the speech and language therapist or developmental team, you can say, educational psychologist, plastic surgeons if they develop any plexiform neurofibroma. So that should be removed, especially on the face. So these are the things. Otherwise, that is okay.
Oh,
Wrong information was not there. And when you are telling about the criteria for the diagnosis, so go like your way was also good. Just to tell, you have told about the cafe outlet sports, so you will have to tell that six or more than six, and that should be less than five, more than 5 mm in pre-pubertal and more than 15 mm more in post-pubertal. And you told me about the leash nodules. So how many leash nodules at least should be? I
I
think
don't
two or
know.
more than two. Yeah, two or more than two leash nodules in the eyes. Then two neurofibromas or one plexiform neurofibroma. This is the criteria. Then first degree relatives. Then is coming optic
Dysplasia.
glioma.
Okay.
Yeah. Then is
All these
coming this
bony lesions will come.
Yeah,
All bony lesions will come in one place, like sphenoid dysplasia, tibial
yeah. It will be in one place.
arthrosis. It is one criteria.
That that will come in one criteria, like kyphoscoliosis, tibial bowing, sphenoid dysplasia. That will come in one.
Yeah, I
Then
think
is
there are
coming.
six,
Then
six, right? Six. There are six criterias, I think. Out of which four should be.
I don't know. Yeah, I don't remember the six are, but I remember the first degree relative.
Mm.
They may have one. The second is optic glioma. The third one is two neurofibroma or one plexiform neurofibroma. The fourth one is two or more than two leash nodules. The fifth one is axillary or inguinal freckling. The sixth one is the sphenoid dysplasia or kyphoscoliosis or tibial bowing. And
Cafe au lait.
seventh is the cafe alert sports, that should be of six or more than six in, and more than 5 mm in pre-pubertal and more than 15 mm in post-pubertal area. Seven are there.
Yeah.
So one
Geneticist.
one thing, this is can can you, geneticist is basically autosomal dominant, but sporadic is too much. So don't if you are going to tell about the geneticist, said that there are sporadic and there are autosomal dominant. De novo mutation is too much in neurofibromatosis.
Not in
Okay.
neurofibromatosis. In all the autosomal dominant, if you observe, sporadic is more common. Even
Yeah,
in.
sporadic is more. Yeah, but specifically in tuberous sclerosis and here is sporadic is more. De novo is more.
Yeah.
So then, yeah, I just close this recording. What is this in? You can